Ikenna, can you move Dr. Lawako to panelist? Okay, we are going to get started. Tell me if you can see me clearly. Welcome everyone and to our fourth day at the Nisa Research Week. I thank you for being with us all this week, and I'm hoping that this has been exciting for you as it has been for me. Today we are going to shift gear to talk a very important thing that all of us have worried about, and that is equity. We have talked a little bit about it, and it became accentuated in research when we came to the issue about the COVID-19 and about equity globally. So I'm excited today that we will be learning a little bit more about equity, not just from the lenses like I talked about it, but really and part of the process. So today we are glad to welcome Helen Scotteres, who is a Warwick Professor of Health and Social Improvement and Implementation Science. She is a fellow of the Academy of Social Sciences in Australia and an inaugural Monash University Maureen Brunt Professoral Fellow. She's also a developmental psychologist who leads a team of 70 multidisciplinary researchers that focus on policy engagement, administrative staffs that are all focused on health and social care across the lifespan. She is pioneering work in the area of equity and implementation science across healthcare, social care, and education. She's going to go over a review of that. And after that, we are going to have our own very own Dr. Professor Tonia Onyeka, who is a professor of anesthesia, pain management, and palliative medicine at the University of Nigeria. She's also the associate director of Ivan Research Institute. She's the current national president of the Hospice and Palliative Care Association of Nigeria. She's an active member of the African Survivorship Working Group, the Implementation Science Special Interest Group, both of the IOTIC, as well as a member of the Implementation Science in Global Health, Consortium for Cancer Implementation Science of the National Institute of Health. She has focused on pain and symptom management, quality of life, and e-health. We're going to start first with Helen. Please, it is your floor. Thank you so much.
Hello, everyone. You can't see my camera, can you? Can you see me?
No, we can't.
I know
So
my camera's playing up. I'm so sorry.
No problem.
I'm so sorry, everybody. I wonder if I can I just jump out and come back in, Eche, just to give it one more shot? Yeah, I'll just leave and come.
So do remember that if you need to ask questions, to put it in the Q&A. If you look beneath, you can see the Q&A. we will take the question according to how they are entered on the Q&A chart. So please go in there and okay, Helen is back.
I'm back, everybody. Sorry. Thank you so much. I'm going to share my my slides. Thank you so much for the wonderful introduction. And let me just share those slides. Okay, you should be able to see my slides now. And can everybody see my slides?
Yes, clearly.
And they're in the right mode. Terrific. Thank you so much. What an honour to be here. I'm really pleased, and I hope my camera stays on. I'm so sorry that it's playing up. It's very, very bad timing, but I'm hoping that the camera will stay alive during this talk. So I'll move on to the next slide because I was very, very graciously introduced. Is my camera still on? Because I feel like it's gone off again.
We can see, but it's blank.
Yeah, I know. Isn't that terrible? Just give me a second.
No problem.
I might just need to end the show again, and I'll just do this again. I won't be able to keep doing that, but I'll just do it for now and see how we go. All right. Just share the screen again. Okay. Okay. All right. So
we can.
you can
Okay,
see
now
my
we
screen?
can see it.
Fantastic.
Yes, we can.
Fantastic. Thank you. So this is my mum and dad. They were born in Greece and they migrated to Australia in the early 1960s. This photo is very significant to me because I think you can tell from their faces that, you know, as migrants returning to Greece, this is where my mum is from in Greece. You can see the pain in their face, on their faces. And we know that migration is never easy. But actually, for my parents, when they were only 18, they were required to leave their families. They could not remain in their families. They were in large families. My mum was one of 9 siblings. My dad, not so large, but one of 4 siblings. But their parents could not afford to have them stay in Greece. At that time, they were living in pervasive poverty in villages. And especially for girls like my mum, a dowry was required and her parents could not afford the dowry. So at the time in the late 50s and early 60s, the government of Australia requested migration. They needed migrants to travel to Australia and to you know, create a life in Australia because they didn't have sufficient workers. My parents were among that group of migrants who arrived and were able to work immediately. But they didn't only work. It's not that they only had opportunities for employment. They also had free healthcare. They had free education for their children. And they had a system that enabled community support. So when I was a little girl and I was at school, in primary school, if there were any concerns, if there were any issues, the teachers would come to my home and they would speak to my mum and dad who weren't able to understand English very well, but they helped them to understand what might the problems be and how they could support my parents in that education. The same with our local general practitioner, our local doctor. That doctor would come to our home if there were any health concerns we had a doctor who was part of the community who was able to come to our home. So even though my parents were migrants, even though they had to leave their families at a very, very young age and come to a brand new country and live in that country without knowing the language and without parents, and even though they themselves had no formal education, they did not finish primary school because they had to tend to the villages. So my mum was removed in grade 2. My dad didn't complete primary school, but he did stay till about grade 5. Even with those, what we would now call childhood adversities, my parents were able to create a very good life in Australia and to remove themselves from poverty, to actually become middle class, to raise 2 daughters, and especially, to create what I would argue is the result of my family. And my family now, my 2 children, you can see there, Dimitri and Chrysula, they are living a completely opposite life to what I did as a little girl, because, of course, my life began in poverty. My parents were poor when, of course, they had me, and they were living as working class migrants in Australia. But that very quickly changed when I was able to finish primary school, finish secondary school, and then go to university. University was free at the time as well. So, of course, there was no issues. I could go straight into university. And the result is Dimitri and Chrysula are both tertiary educated, and, of course, are living a life of privilege. So within just one generation, we can see that the structures of social support not only kept my family, my mum and dad's family, able to work and to educate their children, but also enabled us to remain healthy because, as I said, the doctor was available. The health system at the time for my parents was completely free. There was no private medical system. Everything was free. And we still have free education in Australia, but we know it is very, very different. And access to that education is not necessarily equitable. And to that health system is not necessarily equitable. And so, hence, the talk that I will be presenting today is one that I'm very passionate about. I'm a developmental psychologist. I've always been interested in maternal and child health and wellbeing to give all children the best start in life, irrespective of where those children were born, irrespective of the colour of their skin and irrespective of their socio-economic background. I want for all children what my children have been exposed to. And as you can see there, that was work that I did with Disney, the ability to create a functional and very healthy life for all children. So my work as a developmental psychologist has progressed from basic epidemiological research across to randomised control trials. So wanting to understand initially what matters for children's development and for maternal health and wellbeing. In terms of clinical trials, what works to support the health and wellbeing of children and mothers. And then, of course, moving to that pointy end of what translates. And that's the pointy end that I'm at now, and wanting to better understand how we can push our evidence beyond what we know matters and what we know works. And in particular, from randomised control trials that we know are very gold standard, How do we push that evidence and information to what we know actually works in practice for sustainable outcomes? And that's the sticky, pointy end. That's the implementation side of things that we all know is very difficult. It's not easy. And so I've devoted the last probably 14 years to that part of the journey in terms of translation. This is an example of a body of research that I'd like to talk to you about to set the scene for the topic of equity in implementation science. Healing Matters, the Healthy Eating, Active Living Matters program, provides young people who are in what we call out-of-home care. I'm not sure if that's the same terminology for the audience, but they are young people who have been removed from their biological parents because of sexual, physical, or emotional abuse. They are young people who can no longer live with their biological parents because of grave safety concerns. And so here in Australia, we call that out of home care. And they become, the young people, the children, become the custodians of the government. And the government takes on the responsibility of their care. And in the very, pointy end of the out-of-home care system, there are homes that are set up and house up to 4 young people who don't know each other, children and young people. They are looked after by professional carers who are paid professionally to care for them in those homes. And then, of course, we also have foster care and kinship care, which is provided by families who, so in foster care, obviously it's families who have their own family and take on a young person or a child who's in need of a home. And then there's kinship care, of course, when family take on the care of a young person or child who cannot remain at home with their biological children. So Healthy Eating, Active Living Matters, the Healing Matters program, was developed to support the health needs of children who are living in out-of-home care. And the research that I did revealed back in 2010 that these young people are living with 2.5 times the prevalence of overweight and obesity. So they are 2.5 times more likely than children who are not in care to be living with overweight and obesity. So Healing Matters was developed to provide information and practical resources to the carers of these children and young people so that they can support them to make positive choices and behaviour changes in relation to their health and well-being. So as I said, I'm a developmental psychologist, and when I first started this research, this program of research, almost 14 years ago, I used a very behavioural psychological focus. It was very top-down. I was the one that was deciding how we would go about addressing the concerns of overweight and obesity among these young people. So, top-down approach by a developmental psychologist, a person who had no experience at all of out-of-home care. I'd never worked in out-of-home care. Of course, my children had not been exposed to out-of-home care. I didn't actually even know anybody who lives in out-of-home care. And so I was awarded a grant. I was given quite a bit of money by the Australian Research Council to embed healing matters, this healthy eating, active living matters across out of home care in a randomised controlled trial. But as soon as I began that research, I received a lot of resistance from the carers in the homes who were looking after these young people. And that's because many of those carers are also living with overweight and obesity and are also likely to have experienced out of home care or childhood adversities. And that was something I didn't know when I designed the study, when I received funding, and when I started to work on the study. So you can see there that actually, unfortunately, I was a little Miss Know-it-all because I felt that I stood the issues simply because I had identified that children and young people in out-of-home care are living with greater likelihood of overweight and obesity. And I felt that as a behavioural psychologist, who at the time was also leading other work in the area of childhood obesity, that I should do something about it. And the team that I amassed, my other colleagues who joined me on the grant, were also developmental psychologists. So we didn't even have a multidisciplinary focus. We didn't even have a social worker on the team or someone with lived experience who might have really understood what the concerns for these young people and children and their carers were. So a little Miss Know-it-all who should have probably worn this T-shirt. You know, I'm a professor, so let's just save a lot of time and assume that I'm never wrong. And it was for me a career-changing moment when I realised, even though I had been funded, when I realised that actually I should not be doing this research. I should be much more well informed, and I should have actually partnered with those who do have lived experience of out of home care and understood the issues better. So thankfully, I contacted very, very quickly because I wasn't able to do the randomised control trial. There was just too much um, concern and dissent by the carers and those who we were trying to work with in the randomised control trial. They felt it was very stigmatising, and rightly so, because our focus was very, very explicitly on overweight and obesity. And so thankfully, I contacted sociologists in the UK who had been working with young people in out of home care, looked after children, and who had developed food for thought. And when I had a Zoom meeting with them like this, they were absolutely horrified that I was focusing on obesity. And I was actually really concerned that they were not understanding the importance of focusing on obesity as a health issue. And so their point to me made very, very good sense. As sociologists, they were much more concerned with the value of food, healthy food, and physical activity for creating a sense of belonging, a sense of trust, an opportunity for young people to communicate with their carers in a very safe and trusting environment. And that was a light bulb moment because you know now I have a Greek background, and I think many of you will relate to this. You cannot go to my mum's home without being fed. She needs to feed you, and she needs to open up her kitchen and provide food if you visit her, because that's her way of making you feel very, very welcome in her home. Food for Greek people is extremely important in terms of a sense of belonging, a sense of connection. And so when my sociologist colleague was telling me about this, I thought, my goodness, how could I not have understood this? having a Greek background and very proud Greek background, and understanding the importance of food in terms of our value and trust. And so that was the time at which I literally flipped the paradigm, and I realized that I need to understand before embarking on research adventures. I need to literally hold hands and understand the experiences, the knowledges, the expertise of those who are living in the situations that I am researching. They are the experts. I am in service of them now as a researcher, and I have completely flipped the paradigm. I've completely flipped the narrative. And I provide the research methodologies and skills to support their stories, their concerns. I don't, I don't um, um, create the research questions or agenda anymore. I've literally moved from investigator initiated to strategic prioritized work. And I ensure that my work enables that strategic vision to be allowed. And so the co-designed healing matters, the one that so I stopped doing the research that I was doing, and I actually started all over again. And I brought in young people with lived experience of out-of-home care, and I brought in the carers of those young people. I still have on my team today young people who have lived experience of out-of-home care. They're still part of my team, and they inform the ongoing work that we're doing because, like I said, they're the experts. And together we co-designed Healing Matters. We did that holding hands, and I made sure that their voices and their experiences were listened to and became part of the final product. Now, because of that, and because of that co-design, and because the sector then and the young people and carers really wanted Healing Matters, it's now been included as best practice in Victoria, the state that I live in Australia, and also is being scaled up across South Australia, another state in Australia, and parts of New South Wales as best practice in out-of-home care. So it's an award-winning program now, which is fantastic, and it's creating policy changes in community service organisations that are embedding Healing Matters into their onboarding and professional development requirements. And the Victorian government has funded us to continue this work to develop out-of-home care health promotion guidelines. So all of this is fantastic, and you can see that I've taken it from discovery research to randomised control trial, what we know works research, to now translating and implementing. But unfortunately, not all children are benefiting and benefiting from Healing Matters. And that's because equity as a process was not embedded at the outset. It was an afterthought. And by that I mean that we did leave behind children in out-of-home care, even though these children are the most vulnerable children living in Victoria as a group, as a population. They are the most vulnerable. But within that population, there is still intersectionality. And so if you're a young person in out-of-home care and also an Aboriginal young person, then you're much more likely to have even worse outcomes. If you are a young person in out-of-home care with a disability, you will experience even worse outcomes. If you are a young person in out-of-home care with gender identity diversity, then you are more likely, again, to experience even worse outcomes. So that was a problem with the initial design of Healing Matters, because I designed it much more from a universal perspective for young people and children in out-of-home care. And a lot of people would argue that's what you need to do. But actually, equity was an afterthought. We have since developed up the professional development and resources for Aboriginal children, for children with disabilities, for children with gender identity issues, and so forth. But we did that as an afterthought. That was pushing equity as a lens after the fact, but not embedding equity as a process from the outset when we were designing Healing Matters. And so we know that despite programs such as Healing Matters that are working to address the health inequities of children that are living with most disadvantage, we know that health inequities and the widening gap between the wealthy and the poor are mega trends that are destabilizing societies all around the world. We know that. And that's also the case in Australia. Even though Australia is a high-income country, well over two-thirds, my apologies, 774,000 children in Australia, so almost 1/5 of all children in Australia are living below the poverty line. And that's not acceptable in a country like Australia. So to address pervasive poverty and disadvantage, we need to build the technical knowledge and competency skills for effective translation through advanced theoretically informed implementation science. And this is where equity matters and must be the explicit focus of our implementation science. So we know, everybody knows on the call here, that implementation is an iterative process. And I really love this slide. And I know we saw it yesterday as well. But, you know, we do all of this work. You've heard me talk about the work that I have done in terms of what matters epidemiologically to what works through randomized control trials. We do that all the time. And then we expect a miracle to happen. We expect that our evidence will just miraculously translate and make everything okay. And it's not. We know that the vast majority of programs that have been shown to be effective through randomized control trials no longer are effective when they are translated into the real world. And so despite hundreds of implementation frameworks, theories and models, the how to use implementation science to advance equity is largely unknown. And so thankfully I was awarded a Maureen Brunt Professorial Fellowship by Monash University to tackle this global issue. And Professor Maureen Brunt was Monash's first female professor and the first woman chair of economics in Australia. And that was only in the 1980s. So not that long ago. And because she was born into working class family, and again, her disadvantage of working class was reversed because of her access to tertiary education and her ability to travel the world and receive a PhD. I obviously relate very closely with her story, and it's lovely that her legacy is lasting with impact. And 6 female professors were awarded this year with this fellowship. This is my team that are working on the Maureen Brunt Fellowship with me. And so I need to acknowledge all of them because, of course, I can't do this work on my own. Our vision is to develop Australia's first programmatic multi-sectoral study of equity-centred implementation science across health, social care and education. And I'd like to emphasise the social care and education, because we know that a lot of the implementation science work, the findings of implementation science is through healthcare. But we also know that we must break down sectoral silos, because actually it is the same people that are turning up to emergency departments in our hospitals, or who are needing services in our hospitals, who they are the same people when they are living with disadvantage and vulnerability. They are the same people that are very likely to be known to community and social services. And they are the same people who are falling through the gaps of education. So they are more likely to be more lowly educated. We need to understand that we cannot just focus on one sector to solve health inequities, because actually most of the inequities are also experienced across other sectors. Other sectors are trying to manage those inequities that we know are then, even if they're social inequities or educational inequities, we know they are then associated longer term and also in the short term with health inequities. So really important that we combine and break down silos and integrate health, social care and education. And my professorial appointment at Monash University is all about doing that. And the Maureen Brunt Fellowship continues that aim and that goal. So this is, I'm going to walk you through now the components of my fellowship and the work that we are doing. It's still very early stages, but we have done a lot of work already. This is our lived experience expert network. And so everything we're doing with our lead group, with our lived experience experts. And that's really important, because I've learnt my lesson with Healing Matters and also with other research, but I obviously can't go into all of the mistakes I've made, because that would take a very long time. But the reality is I have made lots of mistakes in terms of the way that we used to do research, and we're moving on and we're making sure that we don't repeat those ways of top-down driven research. So this is our vision, is to capture the voices of our lived experience experts to ensure the end users of our research are also co-creators of our research, so that we're, locking hands and doing that together. And we want to capture and highlight their stories from all walks of life, and embed our lived experience experts throughout the research cycle, and empower them as researchers to work in partnership, ultimately building a more equitable approach to research methodologies and research outcomes. So why a LEE network? Equity-centred implementation science must include lived experience experts. Lived experiences their voices are required to genuinely shape science. We need them to build a different evidence base, and they will better help us understand enablers and barriers. We need them to explore how well lived experience is reflected in research, and early lived experience expert involvement at the inception of research can provide meaningful input. We don't want to, again, think of their input as an afterthought, but rather right from the very outset. So I'm just going to put all the information there, but I'll walk you through it. I know this slide is very busy, but this is a preliminary conceptual framework, a multidisciplinary implementation model for initiating change, and we've called that MIMIC. We've abbreviated that to MIMIC. And we know that from this conceptual framework, MIMIC embeds health, social care and education, and I mentioned why that was important a few slides back, as sectors that perpetuate inequities resulting from structural racism, discrimination, disadvantage and vulnerability. That we know that from the literature. We don't have to keep researching that. We know that for a fact. So interrogating the sectors of health, social care and education. Interrogating these sectors during the foundational stage of, this Brunt Fellowship, we want to discover the what about providing a deeper understanding of what enables or prevents equity being embedded in research and practice. And then moving beyond the what, so you can see the what there across health, social care and education. Then moving beyond the what, the guiding principles and their intersectionality will guide scientific discourse on the how to advance equity through implementation science. So the guiding principles of applying a cultural lens, acknowledging the role of social determinants of health, and the epistemology and ontology of implementation all play a significant role in the way we conduct our research, the reflexivity we use, and the holistic understanding of reality we attain. So we are putting together this conceptual model through rapid reviews of the literature and, trying to understand embedding equity in implementation from a conceptual theoretical perspective, knowing that the work of the Brunt Fellowship will then enable us to further strengthen this MIMIC model. Another program that we have embarked on for this work is equity in program development. Excuse me, I'm just going to take a drink. So we know that there are program development methodologies out there, such as intervention mapping and implementation mapping, and I'm sure that many of you are aware of those. We actually deliver intervention mapping in my team. We have used it a lot to help us with our program development. But we also realised when we embarked on this journey of equity in implementation science that we have to walk the talk, because intervention mapping itself does not necessarily embed equity as a process at the outset. And so we contacted Professor Maria Fernandez, who has been instrumental in intervention mapping. And we spoke to Professor Fernandez and invited her to collaborate with us in exploring equity through intervention mapping, through that intervention mapping framework. And we were very fortunate that Professor Fernandez was able to visit us in Melbourne, Australia, and you can see there a workshop that we hosted for 17 leaders, and they came from practice and policy across 8 organisations, and those organisations were across health, social care and education. And we explored with this group, what is equity-centred practice in intervention mapping steps 1 to 4? What actions, processes or mechanisms support equity-centred practice? And what questions could guide program planners? And so we had a fabulous 2 days with this group and retrieved really, really great data and information and knowledge from these experts, including Professor Maria Fernandez. But we were also fortunate that Professor Carl May was also visiting and was able to also attend these 2 days and again also embed knowledge. So we have had a first go at guiding questions. We don't know if they will remain because we will continue this work with other stakeholders, including 6 esteemed colleagues from Nigeria who are travelling also to Melbourne, Australia, and we very much look forward to working with them to advance our equity in implementation science work together. The final bit of this puzzle that I'd like to tell about today, we are doing other things, but I'll finish off with this massive review that we're conducting that's addressing cross-disciplinary research silos. It's a suite of reviews in education, healthcare and social care. And the primary objectives of this suite of reviews is to identify the in-practice implementation methods used for specific equity outcomes in health, education and social care settings for children aged from birth to 17 years, and to consider what equity implementation principles underpin the identified methods. So across all 3 disciplines of health, education and social care, we have common research questions and objectives, common search strategies, common inclusion and exclusion criteria, and common primary and exploratory endpoints so that we can break down those sectoral silos as noted before and hopefully combine learnings, even though we will report on them separately, combine learnings if there are those learnings that can be combined for consistent outcomes. So we have, as we said, common search strategies. We then obviously have the output of different searches that will overlap between disciplines. So they'll overlap across health, social care, education, common screening process and separate analysis for the different sectors. But hopefully, as I said, some common themes and learnings if that's the way that it falls out. So you can see there that the total papers that we're screening, and we have been through 1 full round of screening now, we're double screening all of them, so we're nearly through that process as well, of 14,027 abstracts. The majority have come from health and education. Not surprising that they have come from health, and not surprising that they've come from education because those 2 sectors tend to publish more. So it's not that it's not happening in social care. It may be that there's not just the opportunities to publish as much across the social care sector. You know, if you're a social worker or community worker. I'm not going to give away the findings because, of course, we still are doing it. But all I can say is at this preliminary stage, from 14,027 papers, abstracts, we have very few that are focused on implementation strategies specifically focused on equity outcomes. So there's lots of abstracts, as you can see, that have equity in the title, equity in the abstract, but are not necessarily focused on that implementation, the strategies that we need to embed to ensure that equity is also embedded as a process with outcomes that are genuinely focused on improving inequities. So thank you very, very much for listening, and I'm very sorry if my camera kept going in and out. That's very naughty of it, but thank you so much for listening.
Let's see. 1 second. Okay. You can hear me well. Thank you so much. So we are going to try to wait. I know there are some questions, but please put your questions in the Q&A. We'll finish the presentation and we'll go into a discussion. So please use the Q&A button to put in your questions, and we are going to take those at the end of the second presentation. We just want to thank Helen. I keep learning new things every year. Once I used to think that equality is equal to equity, and I learned that they were quite two different things. And since then, I stopped talking about equality and talk about equity. Now I'm learning a little bit more, and hopefully things that we all think about as we design and implement in projects. So now let's go over to Dr. Professor Tonia Onyeka to talk a little bit about how the team in Nigeria have tried to use equity to look at the project designs, and also how we look at that in the projects that we implement. Professor Onyeka, please.
Thank you, Professor Esanole, and welcome everyone. So we're going to be looking at the equity and ethics through their lens, well, the process actually, in some of the research we have been carrying out here in Nigeria from the Ivan Research.
Yeah, I'm not sure what's happening to Professor Onyeka. Are you still here? Let's give her a few minutes. Okay, we lost you for a while. Are you still here? Okay, I think she has. You are muted.
Okay, sorry, I think my network threw me out or something. So let me share my screen again.
Okay, if you're having any more trouble, let me know. I can also share it from this.
Yeah, okay. Okay. So like Prof said, what we're going to be looking at is some of the research we have carried out at Ivan Research Institute from the lens of equity and ethics, or we're looking at the processes. I want to make a little disclaimer. Before I make the disclaimer, this disclosure I have to make is that I am faculty in the bioethics program at the University of Nigeria. But the disclaimer is that this talk that I'm going to give is not a talk on ethics. So it's not something that you're going to like an extensive lecture, but it's just to look at what we've done here in Nigeria from the Ivan Research Institute, how we've been able to uphold equity and done our research in an ethical manner. So for us to understand equity is simply fairness. It's just making sure that everyone gets access to the same opportunities. Nobody is left out. And this picture here is quite descriptive. We know that in research, if we want it to be successful, if we want the participants to get the benefits, fairness must be in play. And sometimes people think equity is equality, but they're not the same thing. But equity can enhance equality. Now, a lot of us know that there are 4 pillars upon which bioethics stands on. Autonomy, which is the right of a patient to make choice, and then the right for the patient or the participant of the research to have some form of respect, even when being part of a research. Non-maleficence, does the research cause harm to the participant? Beneficence, is there any benefit of this research to that participant, or if it's a healthcare research patient? And then, of course, justice. Is there fairness? Are we showing fairness to the participant in the research? We have many stories of unethical research, bad science. Examples are far back to the Nazi occupation of Germany, where the Jews they had their legs broken and rebroken just to find out where the Nazis did that, to find out whether those bones, when they would stop, the union will stop, at what point it will stop. Terrible things without getting permission of these individuals. There's so many of them, but I think the one that really comes very close is when we think about some of the reasons why we need to have equity and ethical conduct of research at the back of our minds when we're doing research work. It's important because everyone who is part of that research needs to be treated with respect, no discrimination, irrespective of what their color is, irrespective of where they come from, what language they speak. So that's fair treatment. We also know that when we have equity and ethics, then those participants in the research have some form of protection, and they believe in the process of the research, okay, because it builds trust. Equity and ethics builds trust. And then, of course, whatever results we get from the research we're carrying out is validated, because, I mean, we're doing the research among a diverse population with diverse perspectives, and then therefore it means that most likely those interventions will work out anywhere else we place them. This is a picture of Henrietta Lacks, very popular woman who met her doctors in 1951 for vaginal bleeding, was diagnosed with cervical cancer. She eventually died from the disease, but before she died, she had a biopsy taken and the sample of the cancer was kept. And the surprising thing that ordinarily, when you take samples, bodily samples from individuals, they die, the cells in those samples die, but her own kept living and growing and multiplying, and that's what we call the healer cells. So the cells from her samples are being used in medical science today to test for vaccines, to test for toxins, to test for new medicines. But unfortunately, the downside of this, even though it has a good side, the bad side is this woman was never told, her family was never told that her cells or that the biopsy specimen from her body would be used for science. So, and that is where science failed this individual and her family. Coming closer to home, we are reminded of the Pfizer trials of Trovan, the antibiotic for treatment of meningitis. And Pfizer came into northern Nigeria, Kano specifically, and they didn't tell the parents about what the side effects of these drugs could possibly be. And they gave this medication to the children. 8 children died. Several other children were left with severe neurological disabilities, just as you can see that young girl on the screen, for life, crippled. And they had to pay compensation very recently to Nigeria. So when we think about equity and ethically conducted research, we know that they have to be in place for us to be able to help our people get access to health services. And remember that our people are varied. We have populations that are served. That means they're getting everything they want for their health. Then we have underserved communities that they're not getting everything, especially those communities that you find that the intervention is there, but it doesn't fit them because that intervention was not created in their context. And going back to what Professor Helen was talking about, she was talking about the underserved children, talking about the specific context that a lot of them came in. Many were Aboriginal, many had disabilities, many had gender identity diversity, and yet they couldn't quite fit. So that's some of the problems we find with some of the communities we want to research in. They would be underserved. So we can't just carry whatever intervention we think will help them and just dump it on them. There is a process that we need to follow so that they would be of benefit. We need to make sure we do a number of things. One of them is to make sure that we get the context of that community and create our research around that context. Sometimes the barriers to access for these communities can be something as like race, like ethnicity, like sexual orientation, like gender identity, or even being able-bodied, so disability. So whenever we have our research, the equity and the ethical considerations are things that should be at the back of our mind so that these barriers will not hinder access of our intervention that's meant to help them in these communities. Now, that leads to one big topic, which is implementation science, because it plays a very crucial role in ensuring that the health services are delivered to those that need them, and therefore you reduce disparities in healthcare. But we need to understand that there is no one-size-fits-all approach with implementation science research. Community and replicate it in another community. You always think context. It always has to be at the back of your mind, context. And I'm reminded of context. The cake is a very good example. We know that there are multiple types of cakes, but when you look at closely at each cake, you find out that they may have the same ingredient, but how they're prepared, how they're combined, how they're baked will differ. So when an intervention needs a strong evidence base to succeed, the program, the manner of implementation also needs to fit the culture, the values, and the daily lives of the individuals in those underserved communities, in those places that will need the implementation science. It is simply taking what we know about a thing, and then we're doing something with it. In other words, we're taking what the scientists have said in the lab, they say this works, and then and we try to apply it there to make the lives of to make the lives of individuals in our communities better. So implementation science, in a short word, is a bridge between the bed or the bedside and real world practice. Now, there are a lot of equity challenges in implementation science, and I just mentioned a few. Context is one. I've said that. Sometimes context can be a barrier, all right? Cultural differences, historical differences, and socioeconomic disparities. If you don't take care of context, then whatever research you're doing in that community will not be fully effective, because people will not be able to partake of that intervention that is meant to help them, and they will not get help. Two, power imbalances. We find out sometimes that when researchers go into communities, they want to conduct research, they are busy struggling with the leaders of those communities. And that takes away from the intervention, because the intervention is meant to help the community. But when you come and you're having a tussle in terms of who is in charge, who is not in charge with the leaders of those communities, then you are not going to be allowed. It's going to be difficult for you to actually have an effective implementation. So engagement is key. And we're going to see some of that in the illustrations with what we do here at IVAN. Then equity in readiness. Okay, we find out that before you go to test an intervention, you have this research. You want to test out something that would help your people in your community. There is a tool called a readiness tool. So the ORIC is a readiness tool for you to go and test the climate of that community. Now, the funny thing is that most of the tools used to test climate, the readiness of the climate, the research climate, are tools that are made in the developed countries. They are not that fit the context of our society. They are not that fit the context of the communities we go to. So that is one challenge in implementation science. Then, of course, sustainability. We know that for things to go, for research to move, funding is key. And then when we have problems with funding, then we find out that interventions, even though that they are very effective, they will not be sustained. And when they are not sustained, the health disparity gap widens. So some people have come together and said, what are the things we need to put in our implementation science research so that it can be equitable? And there are 6 things, all right? 6 of them are here: adaptation and cultural adaptation, critical perspectives, community-defined evidence, investments and decision-making to advance equity, dismantling power structure. Remember, I talked about the power tussle between researchers and community leaders, and then building trusting relationships. When you have all these 6 components in your implementation science research or in any research you're carrying out, then your research would most likely be equitable and succeed. So now let's go to the main thing that we're looking at today is how do we at the Ivan Research Institute ensure that our research is ethically sound and is equitable? So I'm going to use a number of examples, but I'll start with the PACE2 study. Now, the PACE2 study is a study that is meant to determine the feasibility and acceptability of culturally adapted and integrated palliative care services to promote the well-being of women living with HIV and cervical cancer. The methodology was mixed methods. And so we're using focus group discussions, we're using surveys, but more importantly, we have co-designed a palliative care package for use. And we use a methodology called the group model building, which Dr. Arono will be speaking to us about in great length tomorrow. So please be here tomorrow to listen and learn about the group model building. And then to evaluate this implementation of our study, we're using FIM, which is feasibility intervention measure, and AIM, which is acceptability intervention measure tools. What are the outcomes? First of all, we've done the first part, which is we have co-created a palliative care service package. We have done that already. And we're at the last stage, which is testing the feasibility and acceptability of the spends that came for the GMB, the group model building workshop that we held here in Enugu last month. We had a total of 60 participants. We flew them in from all over the country, all expenses paid, accommodation, feeding, air travel, for majority, 99% air travel. We also got diverse groups of people who make up the palliative care team. So we had palliative care experts from the 6 regions of the country. We had doctors, we had nurses, we had pharmacists, physiotherapists, social workers, we had volunteers. We also had traditional rulers from the north, south. We had medicine men, yes, herbalists with us in this workshop. And most importantly, we had women with cervical cancer, and we also had women with breast cancer, and we had sickle cell patients attend here, put their heads together to try and create that package and say, what kind of package we want that when we place it within our rural communities, because we know there's a disparity in the services of palliative care in Nigeria. It's top heavy. We find palliative care mainly in the teaching hospitals. So it rests mainly in the urban areas, and there's no palliative care in the rural areas. So what is it that we're going to do? Get together and offer it in our rural communities and help our rural people that really need it a lot. So that's what they were doing here. So we even had a lawyer. We had a lawyer because I'm looking at the lawyer here. She's here. We had a lawyer to advise us on advanced care directives and living well. Now, what are some of the other equity considerations in the PACE2 study? I'd like to talk about a few. Inclusiveness. So this study was about women who were living with HIV and who had cervical cancer. They often have barriers to the early detection, and we know why. one, HIV there's a stigma around it, and cervical cancer, there's a stigma around it too. So you have intersectional stigma, two chronic illnesses giving stigma. That's intersectional stigma. So that's a big problem. That keeps them home. The woman with cervical cancer, a lot of the time, spouse-smelly discharge, issues with self-image. So they just stay home and they don't come early. And when they come, they're towards end of life care. But what we did was that we gave focus group discussions with these women. We sat, we talked with them. We rolled out surveys, and we were able to hear their voices, and we had a lot of perspectives emerge that told us about the unique needs and the barriers that they faced. And this was able to help us together with the co-designing, able to help us now design that package, which we are piloting at the community. The second equity consideration here for this study was accessibility. Remember, I said in Nigeria, palliative care is found in the urban centers. There's no palliative care in the rural centers. So piloting this package at the level of the rural communities, closes the gap in the disparity. It closes it, does it? So it makes it more accessible now for rural people to have palliative care. And then outcome equity. This study aims at measuring and addressing disparities in palliative care outcomes. So we are hoping that if it is successful, then we can find people going, not traveling distances to get to a teaching hospital within their state, but staying within their locality, within their comfort zone, in the comfort of their homes, receiving palliative care. Now, what are the ethical considerations for the phase 2 study? I'll just mention a few of them. One, every participant in this study was fully informed about what we wanted to do, what the risks were, what the benefits were before they agreed to participate. For this study, we have a very strict data protection protocol. No, it is watertight. I'm in the phase 2 study. I don't have access to the data, even though I'm an investigator. It is the principal investigator, Dr. Arono, that has full access to the data for these patients. Then equitable selection of patients. How did we make patient selection equitable? We have what we call the ICON 3 practice-based research network. And on Tuesday, Dr. Olawepo went through describing the structure of that network, where we have sites in the 6 geographical regions of the geopolitical regions of the country. So we have 2 sites per region, and we have teaching hospitals, which we consider centers of excellence attached to these sites, to these hospitals in the secondary facilities at these sites. So this is how we have made it an equitable selection. In addition, I mean, the Nisa has a pool of 60,000 plus women who are HIV positive. And from this pool, we have picked women who were part of this study. And these women come from any and every part of Nigeria, so no one is left out. That's how this study is equitable in the selection. Then we go over to the second study that I would also like to look at, which is the ACCESS study. And ACCESS is an acronym for Accelerating Cervical Cancer Elimination through the Integration of Screen and Treat Services. And the purpose of this study was to identify and test promising implementation strategies that would enhance the integration of cervical cancer screening and treatment into already existing programs in HIV programs in Nigeria. The methodology we used was a hybrid type 3 cluster randomized trial, and the EPIS, which is exploration, preparation, implementation, sustainment, was our guide, and we also used the REAM framework. What do we hope to see? Because this study is ongoing. It's a 5-year study. It's funded by the NIH. The phase 2 study is a 1-year study, also funded by the NIH. What do we hope to achieve? We want to see an improved capacity for the clinical teams that are conducting the cervical cancer screening and treatment. We also want to see improved cervical cancer screening and treatment service provision. And that's going to happen when we have 12 sites already conducting this. Before then, these sites did not exist. So we've already expanded the provision of cervical cancer screening and treatment service by reason of this study. We want to also improve referral completion and navigation to referral centers. So remember that in the ICON 3, that the secondary centers where these studies are happening are connected to the tertiary health institutions. So we have a navigation pathway so that women who are discovered to have an abnormal cervical screen can be referred to the tertiary institution. Of course, we want to increase the awareness and knowledge of this cervical cancer among HIV, especially since women who have HIV are 5 times more likely to have cervical cancer, develop cervical cancer, than women who are HIV negative. So women need to know this. And then, of course, we want to improve the retention rates in care. So these women will stay in the care and be accounted for at all times. So what are some of the things we did in terms of equity? Access and availability of service. This study ensures that the cervical cancer screen and treat services are there for all the participants, regardless of their geographical location, their socioeconomic status, or even their HIV status. But now, because of this study, we're screening all women, but more importantly, we're taking up the women with HIV because they're more at risk. And remember that I've said that we have a pool of 60,000 plus women with HIV who we also took a pool from. So, and these women are all from all over Nigeria. Now, how do we do this? We do this through what we call implementation labs. And I'm going to describe it shortly, what the implementation labs are. They lie within the ICON 3 practice-based research network. They are at the level of the secondary health facilities. Another thing we've done in terms of equity is cultural sensitivity and language accessibility. So we didn't just go in there and say, oh, we have this asset study and we're talking in English. We have site research coordinators who live in those communities, who speak the language, who get these women together and talk to them in their local language and interact with them. We also provided infographics and information flyers, like the information flyers you're seeing in the local language, Hausa, Yoruba, so that the women who are not very well versed in those language in English can get someone who, or they can read their languages and understand what is going on. Then education and awareness. Every participant in this study, they have access to information. Nothing is held back, and the information is usually accurate, because not only do we have the researchers on the field, we also have researchers who are experts. So we have OBGYN experts who are also part of this study to ensure that whatever information that we're giving these women is accurate. Any information about the risk, prevention, and treatment of cervical cancer is accurate. And so at that secondary level, we have a lab. That lab is a team consisting of site research coordinators, and we have the doctors, the nurses, and the adherence counselor that work in the hospitals where our studies are going on. They constitute the implementation lab. So this is the framework that we're using, the EPIS. And EPIS is an acronym for Exploration, Preparation, Implementation, and Sustainment. So we have identified barriers. We have used ERIC strategies to refine, to do the refinement. We have conducted nominal group techniques, and we have done implementation mapping, and we have co-created core and the core plus strategies for this study. We have done the preparation phase. We have also done the preparation phase, which involves implementing the resource team and tailoring and adapting those strategies to the local context of the communities where these women are. And then, of course, tracking any changes that may occur. We are in the implementation phase. We're implementing the two. Remember, this is a randomized trial. We have core and core plus. We're implementing the two strategies. We are doing a lot of things. We're assessing our outcomes, and then with REAM, and then, of course, we're looking at other possible mechanisms down the way. And of course, as we are implementing, we're thinking about the sustainment phase. We can go into these communities, work with these women, help them health-wise, and just go away. We want to have a program that is sustained. And as you see, like Professor Helen discussed the programs they have run and the sustainability. We see the government of Australia has adopted the Healing Matters program. We also want to get to a place where the Nigerian government, the federal government of Nigeria, will adopt the access study, and it will be a federal program, and they will have policies backing it that it will run from now till forever. So I mentioned something about ERIC strategies, and ERIC is an acronym for Expert Recommendation for Implementing Change. So what happens is that these strategies are about 73 in number. So there are things that will help us find what are the barriers and the facilitators to cervical cancer screening and treatment in these communities where these women are. The ERIC strategies also help us to look at ways in which we can train our site research coordinators, our doctors, our nurses, and adherence counselors to facilitate the screening in these communities. Also helps us to fit to local needs. So when we get because the intervention we're getting is something that works in the global north, and we're taking it down here to the global south. So we want to fit it in the local context, take things out that won't work here and put in things that will work, that will make women want to go and screen and treat themselves. That's one of the things that the ERIC strategies does. It also involves everyone. So the entire team. So those are teams at the lab involved. And of course, because they are involved in their hospitals, their management, the hospital management that where these teams are also are aware that is happening. So everybody is in the know. And as such, we can always step down. For instance, we had cases where the doctor in the implementation lab had to japad or had to change his location, and they had a new doctor. It wasn't difficult for the new doctor to come in and continue in that role because everybody around him knew what the access study was about, knew what the aims and the key outcomes we hope to achieve with the access study. Of course, make it last. So we're looking for something that's sustainable. So ERIC also makes it, as it says, that any strategy that we choose, that is what we will help to implement and encourage women to go and screen and treat themselves. That is a strategy we will keep at those localities. And then, of course, the ERIC strategies ensure that we find ways to check on how what we are doing is working and how best we can improve on it. So what are some of the ethical considerations in this study? We at IVAN, we provide clear and truthful information to all our research participants. We don't hide anything. We tell them how the study progresses. And we also have meetings with stakeholders, members of the community, the chief medical director of the hospitals where these implementation labs are. We tell them this is how far we've gone. This is what we're looking to do. These are the next steps. And then, of course, if there are changes to the procedure, we also inform them. We're always monitoring and evaluating what we're doing so that if there are any issues that we did not see that come up, we can make timely adjustments to ensure that the study does not grind to a halt. Then, with regards to community engagement and collaboration, we actively engage with the community stakeholders. That's why we say we have site research coordinators. They are individuals that are working and living there, familiar to the women, familiar to the hospital, familiar to the hospital management. And we have, they gather the patients, sometimes they gather the policymakers like the CMD and other doctors and other people, the management in the hospital, and sit down and discuss and make sure that what we're doing is culturally relevant for that society. And I give you an example. I know, like in the North, we've talked about talking to husbands of women. When women are screened and their cervical cancer screening is fishy, is suspicious. We've talked about do we tell the husbands? What is it? Is it culturally accepted to share this with the husbands? What do the women want? Things like that. We need to be, so we do that engagement so that our research becomes responsive to the needs of the community and eventually sustainable beyond the study period of 5 years. What other strategies are we carrying out to ensure that our studies, not just the PACE2 and the ACCESS study, but other studies that Ivan Research Institute is carrying out is equitable and ethically sound? So we do proactive outreach to underrepresented communities. We recruit staff to ensure that the diversity of the team, the research team, mirrors the general population, and we strive to reach a similar racial or ethnic breakdown in the samples that we have in the region. So for proactive outreach to underrepresented communities, I will talk about one thing we did was to co-design. So co-design is one way that we can build partnerships with the participants or the communities that will use the intervention and us, the researchers. So we sat down with them. That's why I told you last month we brought people over to co-design the PACE2 study. All right. Then targeted recruitment and inclusive communication. Communication is key. We try to make sure that whatever language you are using, whatever medium we're using, whatever we're saying is culturally appropriate. And then, like you saw, we try to translate some of the materials into their languages. We use resources in the community. For instance, we have a study which is known as the Healthy Beginning Initiative. It's also known as the Baby Shower. And for that study, what we did was we went into the communities and we used the churches. So we met women in the churches because we knew it would be difficult to approach women and say, come and screen yourself for HIV. So we went to the churches, and predominantly the Catholic churches. And we know that people of the Catholic faith, they respect their priests a lot. And we had the priests on Sunday carry out the mass, which is the church service, and then make an announcement asking women who were pregnant and their spouses, if they were around, to stay back after the service to listen to a health talk. And that's how we got people to sit down after service, women, many of them with their husbands, to sit down and listen to us about the need to screen themselves for HIV and, of course, to screen their babies when they are done. So that is a targeted recruitment exercise that we did in the Healthy Beginning Initiative. Educational workshops and training programs. Right now, we have a study, the Community Vital Signs study, that seeks to take the blood pressure of individuals in rural communities and then, of course, navigate those with with elevated blood pressure to the secondary health facilities where the doctors will confirm or disprove whether they have hypertension or not. So we see that we have to sit down with these the stakeholders in these communities, the leaders of thought, the community leaders, and other individuals there, and talk about the process, what it entails, the risks, the benefits, and give them information on the blood pressure, how to take a blood pressure, and how to treat hypertension properly. And we do that using individuals that are staff of IVAN that we call community research engagement officers. They also live in these communities, and they're going to be focused on taking blood pressure and navigating those who have raised blood pressure values to see doctors in the secondary health facilities. Then diversity of research teams. So how do we ensure that our research teams are diverse? For us at IVAN, what we had done is to do targeted job advertisements. So we put out adverts in LinkedIn. And as you know, putting an advert in LinkedIn is like putting an advert to the world. And that way we're able to get people from we had, when we advertised for the post of site research coordinators, we had applicants from India, because we put it on LinkedIn. We also put it on the Nigeria Implementation Science Alliance website. So placing job adverts in a number of networks, especially those with big reaches, can help you get individuals that can be part of your research team with diverse backgrounds, diverse ethnicity, that can fit in what you want to do. And when we did this, also, we're able to get those individuals that are living in those communities. And that's why our research, that increased the validity of our research. Then, of course, diversity in hiring the members of the committee that will screen those that you call the part of your research team. At Ivan, we use both local and foreign research collaborators who also have diverse backgrounds, so that we're able to eliminate unconscious biases and ensure that any evaluation of any applicant is fair and free. So we are talking about racial or ethnic breakdown in research samples. Nigeria is a multicultural, multi-centric nation, a population of over 200 million and over 50 ethnic groups. How can we at Ivan make our research relevant? Okay, so that we don't do research and they say, oh, this research is just for the Southeast, it's only for the North Central. What we have done is create the ICON 3 practice-based research network, which has 12 sites, 2 per region, from which we can do studies of any sort. And on Tuesday, John was able to tell us that we're doing studies in palliative care, in neurology, in cardiology, we're doing studies in HIV, in OBGYN. So all those studies, because we are taking samples from the regions, the outcome will be representative of Nigeria and not just any single region of the country. And that is what makes for equal representation and inclusive outcomes. Other things that we're doing is adding telehealth components to our study. So presently we have a study on mental health where the Ivan Research Institute has developed in partnership with the University of Nigeria, specifically the Department of Psychology at the University of Nigeria, Nsukka. We have a telemental health lab. So now we have the luxury of having trained psychologists who will sit and take consults from any part of Nigeria for our women on the access program, the women with HIV, the women with cervical cancer, because with these conditions, there are lots of morbidity, depression, anxiety, because of what those conditions bring with them. So these women now have people they can call and talk to. We have people that we have expert psychologists who can assess them from time to time and know when to intervene in cases of anxiety and depression. Other things we have done is that we have had study participants who live far away, and we say, listen, we need you at this location. If you come, we reimburse you. That's what we did for the GMB we held last month. So a lot of them came from a lot of far places, and we reimbursed them. We reimbursed them for their land travel, even though we also paid for their air travel. So just to make sure that the context of our study is right, is relevant to the communities that will receive the intervention. So what are the key points that these studies have raised? The importance of inclusivity in research. So we remember that when we're doing research, at the back of our minds, our populations are diverse. And in those diverse populations, we have a lot of underrepresented or disproportionately affected individuals in those populations. So we need to have them and pay particular attention to them. We also need to assess for the early detection and treatment, and of course, sending those women for palliative care. So that is where we're going. Then we are using culturally sensitive and understandable methods to obtain informed consent. There's no one way. We study the communities and we say, this is the best way to get informed consent from them. And we get true informed consent because the patients are aware. Then, of course, the engagement. No research can thrive in the community without engagement. We are interfacing and continually interfacing with community leaders. And what that has done, it has increased the trust they have in us, increased the trust in intervention, and they speak about it and encourage the members of the community to be part of it, the women to be part of it. And what this does is that it increases the relevance of our research and, of course, the impact. What I think that in future we should look to do is to ensure that we find ways of entrenching the implementation of equitable and ethical research practices in research early. How can we do it? Presently, we know that we have the discipline of bioethics that does it, but if you look closely, you find out that there's nothing about bioethics in the Nigerian undergraduate and postgraduate curricula. For the medical curricula, there's nothing like that. And in many other medical disciplines, nursing, I think that one of the things we need to do is to look at how we can put, even if it's a 1-hour lecture, even if it's a 1 month, that we can have students go and sit with researchers in the communities and see how they do these researches. I know that medical students do a bit of community medicine, but without bioethics, then we're not able to allow them see how research can be equitable and ethically carried out. So I would like to end with this quote by Professor Sherita Golden. She's the immediate past Chief Diversity Officer at the Johns Hopkins Medicine University Hospital. So she said this, she says, at the end of the day, diversity and inclusion in healthcare is a matter of life or death, because our biases can impact our healthcare decisions in a way that may disadvantage patients. So let's remember that for our research to be successful, it has to be ethically conducted and it has to be equitable. And this is where I'll stop and say thank you. I think we're okay. Prof is here.
Thank you so much. Sorry, I am trying to unmute my thing. Thank you so much. And thank you so much. I think at the end of today, I begin to think differently for myself in designing the studies of how I have to make sure that my studies are equitable, and that equity is one of the things that are taken into decision as we design, as we implement, and as we report, even there, to make sure that even reporting studies to communities where we conduct studies is one form of way to make sure that everybody is involved in what we do. So I'm going to go ahead and go a little bit and look at some of the questions in the Q&A. Again, remember, if you have questions, to put them in the Q&A button. I won't be picking them up from the chat box. So one of the first question here is talking about power structure. And this question is to you, Helen, and it's saying, how can power structure be dismantled in an African setting where power structures are very strong and you need to dismantle them to be able to do equitable research? How have you done that in your experience in research? Helen?
Yeah, that's a very, very good question. And even though we live in different countries, there are still very powerful structures, aren't there, in government and political agendas. Unfortunately, it's not easy. And the only thing I can suggest is that you do not give up. So as Professor Annika has eloquently described, joining forces with the community and building advocacy that moves beyond just your research team. The more people, the bigger the community, the louder the voices, the more likely you are to potentially have some sway. It doesn't mean that it will be successful. But when I stopped my top-down driven approach to research and I did join forces with lived experience, with community organisations, with advocates, the groundswell was much, much bigger than me as an individual or as a small research team asking government to listen to me. It was actually the community service organisations, the chief executive officers of those organisations. It was others who were knocking on their door as well. And Healing Matters was then taken up and is now a mandated regulated program. But it does take a long time. And I did start this in 2010. So it's 14 years down the track. So I'm sorry I don't have an easy answer, but I do suggest you never, ever give up. You keep developing together with the community the evidence that shows it will also be beneficial to the government. They will save money if they do this type of research.
One of the things, thank you so much. One of the things we noticed is that sometimes when we think about men and the power struggles, and some of those things are also not understanding the role. For example, we were trying to increase breastfeeding among women, pregnant women after delivery. And one of the things we found out, we decided to create two interventions. One of them was focused on educating the women about breastfeeding their children. And then the second thing was the other arm was to educate the men, not the women, about breastfeeding, the benefits of breastfeeding. So even though we wanted to increase breastfeeding among women after pregnancy, we targeted the education to men, their partners, to tell them about the benefits of breastfeeding, to tell them why their wives need to do it, and to tell them how they can help support their wife breastfeeding. And we compared these two groups to see whether there was anything. And you will see that those power struggles, sometimes that if men understand some of those things that you're trying to do, for them, they said, oh, the women get all the intervention, everything is focused on the women. But what people don't understand that if you do understand some of those power shifts, that you can also use them positively in a way to educate the men and actually change that power dynamic. So the man understands, you want your child to be breastfed? Yes. Well, you need to go do the dishes while the woman breastfeed. Or maybe you need to help in some way and do some other things. So I think continuing to intervene in a way through education and through this type of applied interventions may help us in breaking down. Like Helen said, there's no one person that can knock and open that door. And there are multiple people need to keep knocking to open that door. There's another question here, and this question is talking about access to funding. And it's talking that they have been designing studies to address health disparity and advance health equity in one of the regions in Nigeria. And they're wondering, are there opportunities where that fund such global funding from the Australian government?
Yes, another good question. Unfortunately, there isn't a lot of funding schemes. There are traditional schemes from the National Health and Medical Research Council and the Australian Research Council. But I think for this specific equity type work, we do need to look beyond and we do need to seek also philanthropic funding. So funding that might come from philanthropists who are considering pouring their investments into supporting this type of research. But again, the short answer, unfortunately, is that the research schemes are not necessarily focused just on equity, and as such, they're vastly competitive, and so
I
it's
think
not
you did
necessarily the
mention
case that
something
you can find the research. Yes.
You did mention something that is important. It's not about looking for research to focus on equity. It's about having equity as part of your process in every research you design. So
Correct.
even though there may not be funding that is directly for you to do equity, but you're talking about what we just discussed about breastfeeding. And yes, that may be about breastfeeding, but you can integrate equity into it, and you are trying to make sure that yes, the women are the same person that's going to breastfeed. Yes, it's the same person that's going to cook for the dinner. Yes, it's the same person that's going to wash up, but there is a role that men can play. So again, even in your designs, that you could think about a way to think of equity in your designs of every particular study. That even though you may not find or difficulty finding research that is focused solely on equity, that you can integrate equity in the design of the research that you propose.
That's
There's
actually
another
a
question here
brilliant
for
result.
you.
Yes, brilliant answer. Thank you. That's excellent.
This question is the last one. It says, how can community mobilization intersect with implementation science research?
Yeah, I mean, it's fundamental. It's critical that community mobilisation is a requisite. You should not move forward with implementation science. That's my view. As we just heard, it should be embedded as a process right from the very outset. So together with community leaders, with those who are influential in the community, who are potentially the people who can make a difference across their community, we must hold hands and we must do the research together. So a really lovely example of that was the COVID-19 crisis that we had, and in our state of Victoria, in Australia, we were locked down for almost 2 years. There were very, very severe, drastic measures to try to prevent people from getting sick. A lot of criticism of the government for taking such very harsh intervention measures of literally locking us down. We weren't allowed to be out of our homes for more than 5 kilometres from our home, and there were certain times of the day that we could not leave our homes at all. And so for those who were living in poverty and disadvantage and vulnerability, they were, of course, more severely affected by the lockdowns. But also, we have a very large population of multicultural communities, and none of these, solutions to the COVID-19 pandemic were actually co-designed. And so I got together with multicultural community leaders, and we very quickly wrote a perspective piece and then published that and used that for advocacy to the government, which did change the way that they approach their interventions with multicultural communities. And the very, very clear message from multicultural communities was that you must involve us in the solutions, whether that's a religious leader, whether that is in our case, a very influential Muslim football player came out and, because of his popularity, spoke to the Muslim community and told them, please, my mother has experienced COVID, she nearly died, please social distance, please wash, please sanitize, please vaccinate. And that made a huge difference in vaccination uptake in the Muslim community, because he was such an influential and trusted person. So we do have to join forces, mobilise our community networks, and we need to do that right from the outset.
Thank you so much. Here is another question that is asking about and any of you can take it on. This is talking about what is a hybrid type 3 randomized trial in research.
Okay. Let me say it in simple sense. So a hybrid type 3 randomized trial is simply a kind of research where the people that you want to look at, or the people you want to offer the intervention, you take them into two. Okay, you divide them into two. So one group will have the intervention, and the other group will have their regular whatever they were doing before you came with the intervention in that community. And what you're looking at is how effective is the new intervention, and how easy is it for that intervention to be carried out. So those are the two. They're looking at effectiveness and implementation. So that is essentially what a hybrid type 3 randomized trial is.
And that is the basis for every hybrid type of designs. So there are three types, like you have a hybrid type 1, a hybrid type 2, and a hybrid type 3. And in all those randomized kind of trial, you are looking at one that is looking at efficacy, you're looking at one that is looking at mostly at effectiveness, you're looking at one that is looking at implementation outcomes while collecting clinical efficacy. So in a hybrid type 3, a lot of your focus is also on implementation outcome, where you collect the data on the clinical outcome. Whereas in the type 1, you are focused on the clinical outcome, on efficacy, collecting information on the implementation outcome. In hybrid type 2, you are equally measuring both the clinical outcome and there. But it's a very common, interesting, and increasingly being used to design studies where it is not just where we just have the clinical outcomes from studies, or studies that either do one of them or the other. But in this case, we can measure both outcomes. There is one more question here. This is to you, Tonia. It says, how do we incorporate those with disabilities, like the deaf and people in our community, to benefit in this health research, like the palliative healthcare scheme?
Okay, it's simply, I mean, the easiest way is to co-design an intervention with them. So it's to bring them as co-researchers. Okay, so there's an aspect of medicine now that is increasingly popular. It's called citizen science. So it is the aspect of research where individuals who the research is all about are part of the research team. So they sit like with the scientists, and they are able to give their perspective. So the deaf person is a researcher on the research team and is able to give his or her perspective as a deaf person with regards to whatever the research is all about. So that is one way. Another way is the way we have done in the phase 2, where we have co-designed. In this co-design, during the group model building, we did not get people who were sight impaired or hearing impaired. But if we had done that, what we would have done, we would have gotten Braille. Their own information will be in Braille. So the blind people will read their information and be able to contribute with Braille. And then the deaf people would have people with who do sign language to also be at those meetings with deaf people, to be able to communicate to them and give us feedback on what they are saying, that is how the package should be. So I think maybe I think maybe it's fit for me to say that's one limitation, is we did not consider disability in this package. But going forward, as we refine the package, we will consider including disability in it.
Thank you. Maybe this brings me to a question for Helen. You talked a little bit about lived experience expert. I've never really had that word before, but I was just thinking whether, when we were, for example, designing studies for individuals living with sickle cell, then we bring someone with sickle cell to be part of that co-designing, part of that planning, which is what we did. Somebody is looking for a program for or design an intervention for people with brain tumor, and you bring someone who have a brain tumor or a survivor to be part of that and things like that. With those kind of patient participation in research, is that what can be defined as lived experience expert?
Correct. That's exactly right. So the lived experience experts actually decided to call themselves that. What you might have heard of is consumer and community involvement. So consumers or end users, that's quite a common term. But they're starting to not like the term consumer, and they're wanting to have that equal footing. So they're preferring to be called lived experience experts. And once you use the word experts, what you're signalling there to policymakers and to the broader public is that actually lived experience is very important. It is an evidence base that we do need to listen to, and it is equally as important as the evidence that we amass through our systematic literature reviews, our meta-analyses, our epidemiological work. We do know that what is often the case is that the literature that is published has severe limitations at times, because there are certain groups of participants that will put their hand up to participate. There are certain groups of participants where we can collect data that skews it towards a particular demographic. And as we heard yesterday by our esteemed colleague Byron Powell, those strategies, the ERIC strategies, are very likely, and the implementation frameworks and models that we are using well, we shouldn't even say very likely, have been developed with data that is not culturally diverse and representative of, all people in the community. And so we do have to ask the questions. We do have to ask those questions about, are our frameworks and our strategies actually exacerbating health inequities? Because they have not been designed with and for and by people from a diverse background that also have important lived experiences that we need to understand. And we do know that the Western white privileged world has dominated this area of science. That doesn't mean it's bad, doesn't mean it's wrong. It just means that it's time to consider how we move beyond one mono, monovision that is very white and colonized and colonial, has one perspective. And as I said, it doesn't mean that it's wrong, but we do have to push beyond that and really, really embed from the outset lived experiences, data, expertise of those that are from very vast backgrounds.
Thank you so much. I think one of the things we are increasingly doing is that we are making them part of our stakeholder committee. Not only do they participate in co-creation, but they actually hold us responsible in the research that we do to ask these questions that we may not ask. We're trying to include them in those kind of committees when we're writing grants, involving them in the co-designs when we're designing them, and the stakeholder committee, so that we're held responsible while we're implementing them. And one of the things that we try to do is also to make sure that every research that we do, that we present it to the community where we got the, where before we publish and share all those results, that we present that result to the community where we derive those results from. So they are the first to know about the data that we collected from their community before those are shared externally. It's our own way to say you are part of this along the way, from the design, from the implementation, even at the result stage. You are the first to know. Thank you, everyone. I think we've come to the end of today, and tomorrow is another day. Professor Tonya, if you can pull up the schedule for tomorrow. Tomorrow is going to be our last day of the Nisa Research Week. We do this every time with 2 hours each day set aside to bring this type of exchange where we bring in 2 different experts to give their experiences with the same topic from 2 different lenses or 2 different perspectives. So we hope that you enjoy this and that you can still join us tomorrow. At the end of tomorrow, we will, if the speaker has made their slide available to be shared, these slides will be shared on our website, and we will send a link to your email, the email that you used for registration for the conference. That's what we use. So if that email is not correct, you can put up your email tomorrow. We are going to collect updated emails tomorrow at the end of the presentation tomorrow. we'll collect updated emails. We don't collect them as they go by. So if you put them on Monday, Tuesday, Wednesday, Thursday, we usually don't do that. But on Friday, we have an opportunity for, at the end of that presentation, to take updated emails, and we'll send those links to those emails. Thank you, everyone. Professor Nyeka, did you want anything to add?
No, just to say thank you, everyone, for joining. And tomorrow is the icing on the cake. Don't miss it.
Thank you. We're going to talk about group model building, where Dr. Ballard is going to be here, and Dr. Idemile Arono will join us from the experience she had doing the first group model building exercise that we know of a Nigerian person right here in Nigeria. So alone, and that's something that we really pride as something she has done in her career. Thank you, everyone, and join us tomorrow. Thank you. Thank you, Helen. Thank you.
Thanks, Helen.